All right, we are going to discuss in this video the hormones, specifically estrogen, progesterone, and the androgens or testosterone. So our objective here is to identify the major therapeutic uses, side effects, and toxic effects of the hormones I just mentioned. We're going to focus in the beginning of this video on the female reproductive hormones. And these are steroid hormones. Estrogen, progesterone, and testosterone are steroid hormones, and they are responsible for the growth, development, and the reproductive health of females. They have all kinds of actions. When we think about pharmacology, we think about either replacing or overriding or antagonizing the actions of these hormones. But in terms of pathology, both deficiencies, and excesses of these hormones can really have a profound effect on the health of females. We know that estrogen and progesterone impact virtually every body systems, probably a little bit more profoundly when we think about estrogen. And this includes blood coagulation, the health of blood vessels, the health of bone and the density of bone, muscle metabolism, and behavior. So all kinds of action here with these hormones. In addition to that, we also think we're probably a little bit more familiar in terms of thinking about these hormones in relationship to reproductive function, including fertility, labor, delivery, and lactation. So here's kind of our feedback loop. So the hypothalamus releases gonadotropin-releasing hormone, which then stimulates the anterior pituitary to release luteinizing hormone and follicle-stimulating hormone. LH and FSH will, in the female, have a direct effect on the ovaries, both of them. FSH is responsible for the maturation of the follicles, which secretes more estrogen, and the development of the corpus luteum. And that's a little bit more involved in the progesterone side of things. And then the progesterone also is going to be involved in the stimulation of the endometrium. And estrogen as well, both of them, I should say. So there's a lot of things going on here with these hormones. And of course, as the hormones estrogen and progesterone increase in the blood, then that should feed back to both the hypothalamus and the pituitary, and decrease further secretion of LH and FSH. So there's all kinds of things, super complicated, and there's all kinds of places where this can kind of get messed up. So I'm sure you probably saw something like this in your physiology class, but the female reproductive system is incredibly complex, and it's really it's really this sort of a dance between these two hormones in terms of what's happening in relationship to what's going on in the ovaries and the ovarian cycle, and also what's going on in the uterus. So there's a whole bunch of stuff that we sort of think about. And I don't need to dive into this too deeply. I just kind of wanted to illustrate the complexity. But because we're looking at estrogen and progesterones in this unit, I kind of wanted to look at the hormone levels, where they spike, and what they're responsible for. In the next video, we're going to talk about oral contraceptives, which also we're going to revisit these hormones as well. All right, so I guess we can go on here. Okay, let's talk specifically about estrogen for a little bit. So really, there's 3 different steroid hormones. When we think about estrogen is kind of a generic term that is referring to one of these 3 hormones. So the 3 hormones are estradiol, estrone, and estriol, and they differ in terms of their potency, and how much of these things are around. So the hormone that's the most potent and also the most abundant is estradiol. And The one that's least potent is estriol, and also tends to not be around too much in general circulation. So when we think about estrogen, what we're really thinking about is estradiol. So the role of estradiol is that it's responsible for the maturing of the reproductive organs and also for the appearance of secondary sex characteristics in females. We know that estrogen has an effect on the heart, the liver, the blood vessels, and the bones. I want to say that one thing about the liver is responsible for metabolizing estrogen from the more potent to the least potent, which is kind of outside of the scope of our class, but that's something that you might come across at another point. So for a female, it's important, especially when we start to think about estrogen-dependent problems like estrogen-dependent cancers. I'm thinking specifically about breast cancer. There's some evidence that elevations in blood, in estradiol and estrogen, increases risk. And one of the things that we kind of want to think about is, or consider whether or not the woman has a compromise in her ability to metabolize this more active estrogen to a less active and potentially less problematic form. So that's something that you might come across. It's not really for the context of our course, but it's something to think about. So some of the specific things we know about estrogen is it decreases LDL cholesterol. That's the one that's considered to be not so good, and increases HDL cholesterol. That's the one that's considered to be protective against cardiovascular disease and vascular disease and other things. We know that estrogen blocks the resorption of bone, so it allows bones to grow longer and stronger in younger women, but also potentially maintains bone mass in women that are getting older. And that's probably why we see a decrease in bone density right around when estrogen levels start dropping off in females when they reach that menopausal period. All right, so let's talk about why we might give estrogens. And again, there's different forms, and there's so many different ways to give estrogen, which we're not going to get into all of it right now. But when we think about estrogen being used therapeutically, for the most part, at least in the conventional setting, it's really some sort of estradiol. So what we know about estrogen and why we might want to give it therapeutically is, one, it suppresses ovulation, and we're going to have a longer conversation about this in our video on oral contraception, but estrogens are given with progesterone for birth control. We don't ever want to give estrogen unopposed to a woman who has a uterus because it can cause an increase in the uterine lining, and without the progesterone, the uterine lining won't shed, so it increases risk for uterine cancer. So that's why unopposed estrogen is not recommended. So if we're thinking about suppressing ovulation, we want to make sure we give some progesterone as well. Another very common use for estrogen is for menopausal women, and it's to decrease the undesirable effects of menopause. Things like weight gain, hot flashes, sleep disturbances, mood disturbances, those kinds of things. So estrogen can be helpful, is often helpful in that period. So not as common, but another potential therapeutic use is if somebody's got what we refer to as sexual infantilism. Basically, that means that their secondary sex characteristic in their uterus isn't developing properly, and estrogen would be a potential therapeutic intervention here. If we're trying to inhibit lactation, estrogen can do that. I mentioned already menopause, and in the previous slide, I talked a little bit about bone density. Bone density can be maintained in postmenopausal women with estrogen. Not indefinitely. It seems to be most effective a couple years, like up to 5 years postmenopause. And really what estrogen appears to do is just kind of stop any additional bone loss. It doesn't appear, at least there's not a whole lot of good evidence to appear that estrogen actually can increase bone density, but it kind of holds steady, if you will. And I'm going to have the final video in this unit is going to be on bone density, so we'll revisit this a little bit there. And I'll talk more about some other options for bone density outside of just estrogen. All right, and then estrogen can be used in some cancers. Postmenopausal women have with certain cancers. The one that I'm thinking about is ovarian cancer. So estrogen is kind of tricky because it seems to be protective against some cancers. Ovarian is one of them, but increases the chances of other cancers. And the two cancers that we know that are estrogen sensitive are definitely potentially breast cancer, depending on the type of breast cancer, but also cervical cancer. So while it may protect against ovarian cancer, it may increase the risk of breast cancer and potentially cervical cancer. One other use outside of females for estrogen is in men with advanced prostate cancer. The main side effects of estrogen are going to be cramps, bloating, breast tenderness, mental depression, skin eruptions, specifically acne, changes in libido, and it can be an increase or a decrease in libido. It sort of depends on the woman, and weight gain. Headaches are quite common. Also is associated with hypertension, fluid retention, and edema. That's probably where that weight gain is coming from in terms of the fluid retention and the edema. Also, nausea, vomiting, and diarrhea is pretty common. If you're giving estrogen to a menopausal woman, you would not be surprised if they start bleeding, right? You're basically overriding or replacing the hormone that they're lacking, and so they will start cycling again, potentially, or at least spotting. So we want to give the most, and I think this is good advice for estrogen in general, given its association with cancer, that you want to give them the minimal effective dose to help treat the symptoms that help prevent the symptoms that you're trying to treat, but decrease the risk of cancer. There's a bunch of cancers that seem to be associated with estrogen use. Endometrial cancer is one. I guess, again, and I've sort of just mentioned this is why we don't want to give unopposed estrogen. Depending on the dose and the duration, the risk increases anywhere from about 5 to 15 times. Although some ovarian cancers and uterine cancers can be decreased by very small doses. It's kind of confusing with estrogen in terms of what's really happening here in terms of risk and stratifying some of these risks. Pardon me. Sorry, that last bullet there is worded funny. It's confusing. So there have been cases of vaginal cancers in young women whose mothers were treated essentially with a type of estrogen early in their pregnancy. So they refer to these women as DES daughters. So diethylstilbestrol, or DES, was the drug that was given to some women during pregnancy, and those women's daughters have an increased risk for vaginal cancer, which is not a very common cancer. Another side effect or potentially toxic effect that is not super common, but definitely not unheard of or rare for that matter, is the risk of thromboembolism. So it seems that estrogen affects platelets in such a way that it decreases clot time. So if somebody is at an increased risk for clotting, like for example, they've had a surgical procedure, or they have are going through a period of bed rest, then estrogen should be suspended in those women. I want to talk for a second about hormone replacement therapy and hormone and a study that was reported. I think it was when this started coming out in the literature was around 2002. Prior to that time, hormone replacement therapy, so this is replacing estrogen primarily, for menopausal women was considered standard of practice, and everybody recommended it, essentially. Not everybody, but most people. Anyway, so they started this study, which was a huge study. You can see the number, and this was called the Nurses' Health Study. And it was looking at about over more than 16,000 subjects between the age of 50 and 79. And basically, the study, the objective of the study was to prove the efficacy of estrogen, and just essentially how great it was for everybody and why everybody should be on it. I'm sort of oversimplifying there, but that's more or less the gist. And so they did this, they had the two groups, those taking estrogen and those not taking estrogen. And unfortunately, what they saw was an increase, a statistically significant, although it looks worse here than it actually was in terms of numbers, increase in breast cancer in the treatment group, strokes in the treatment group, blood clots in the treatment group, that was the big one, heart attacks in the treatment group, but it did show a decrease in the incidence of colorectal cancer, colon cancer, and bone fractures. So, however, I should say that there wasn't any difference in the death between the two groups. So, when you really look at the absolute numbers, per 10,000 patients for a year, the absolute numbers aren't huge, right? So 8 more women developed breast cancer in the test group than the control group. 18 more women developed blood clots in the test group versus the control group. So we're not talking about huge numbers, but it was still a trend, and it was surprising. And as a result of that, it kind of was like pandemonium in the OB/GYN offices, where people were traditionally prescribing a lot of hormone replacement therapy because the media got a hold of this and just sort of got blown way out of proportion. However, it is something to think about. And it's interesting because we thought that estrogen, knowing its effects on, say, the cardiovascular system and the vascular system, etc., that they assumed that the cardiovascular risk would go down with estrogen, but instead, surprisingly, it went up. The breast cancer is not a big surprise. Now, knowing now what we know about genetics, and that we have these cancers that are estrogen sensitive, but that wasn't really known at that time either. It's all fairly new information. So as a result of this, people started really rethinking their whole idea around hormone replacement therapy and the safety of hormone replacement therapy. So I just wanted to mention that to you. Let's talk about progesterone for a minute. So when we think about progesterone in terms of drugs, we're really thinking of progestins, which are a synthetic version of progesterone that essentially has the same action as natural progesterone. Natural progesterone isn't available orally, and it's just not available in an administration form, but the progestin works as well. The same, if not as well. So for the most part, estrogen and progesterone are going to be given together. We saw our graph a little while ago of the sort of interplay between estrogen and progesterone, its relationship to both the ovarian cycle and the menstrual cycle, uterine cycle and the menstrual cycle. So the two of them really work in tandem. It's definitely sort of a concert effect, sort of symphonic effect with estrogen and progesterone. So they very definitely, their peaks and valleys, if you will, very definitely play off of one another. And it's essential that the levels of both these hormones are maintained adequately for optimal function of the ovarian cycle, the uterine cycle, and the menstrual cycle. So one of the big things estrogen and progesterone do is they essentially provide a nice environment for a fertilized egg. So they thicken the endometrial lining in preparation for fertilization and implantation. However, if pregnancy does not occur, then the ovary will continue to secrete progesterone. If pregnancy does not occur, the progesterone levels will go down and the uterine lining will be shed. If pregnancy does occur, however, the ovary will continue to produce progesterone in order to maintain that nice, healthy, and thick endometrium until the placenta can take over the role of producing the hormone itself, which is generally towards the end of the first trimester. All right, so therapeutically, progestin is going to be the drug of choice for lots of uterine abnormalities. And what we're thinking here really is dysfunctional uterine bleeding, of which there's all kinds of things that can cause that. We're not going to go into all of those. But dysfunctional uterine bleeding is defined as bleeding on a non-cyclic basis or in abnormal amounts, and also associated with anovulatory cycles. Possible causes of dysfunctional uterine bleeding can be early abortion, pelvic cancers, thyroid disorders, pregnancy, and infection. So progestins are a part of the oral contraceptive picture. They can be given and are most frequently given in combination with estrogen, but they can also be given alone. When we give estrogen-progestin combinations or progestin alone, we're suppressing ovulation. That's the goal of oral contraceptives, and or preventing the development of the endometrium. So menstrual cycle abnormalities are another potential therapeutic use for progestins, which I kind of talked about at the top. This would be amenorrhea, endometriosis. I mentioned abnormal uterine bleeding already. One of the things that progestins have been traditionally, or maybe not traditionally, but have been considered for, is for women who have habitual abortion or are having habitual miscarriage. And that's kind of, the jury's out on that. You can sort of find data to go either way, but the larger body of evidence shows that progesterone on its own has not been that effective at preventing these frequent miscarriages, or spontaneous abortions, as it would be called. There is some evidence that administration of progesterone to pregnant women can potentially cause cardiovascular issues, malformations, and limb reductions in the fetus. All right, so again, the take home here is the most common uses for progestins are going to be dysfunctional uterine bleeding and or uterine menstrual cycle abnormalities, or as oral contraceptives. And that's by far and away the most common use of progestins. Side effects of progestins are going to be the same as estrogen, but we worry less about blood clotting and cancer, especially if you're giving a kind of a low potency form. High doses of progestins, just like estrogen, though, can increase the risk of cardiovascular disease and stroke. We don't really know, with that Nurses' Health study, we don't really know which was more likely the culprit with the cardiovascular disease and stroke scenario. So estrogen and progesterone have both been implicated. The most common side effects of progestins are going to be weight gain, edema, fatigue, and depression, very similar to what we talked about with estrogen. All right, the last thing I want to mention here are the androgens, specifically testosterone. This is the role of testosterone in the male. You see the same players, gonadotropin-releasing hormone, stimulating the anterior pituitary to release luteinizing hormone and follicular stimulating hormone. And these hormones are going to ultimately increase the secretion of testosterone and also the formation of sperm, spermatogenesis. So the testosterone is an androgen, and it's going to have masculinizing and anabolic effects in both men and women. The anabolic effects of testosterone are increased muscle mass, increased bone density, and increased red blood cell mass. Testosterone is a primary androgen produced in the body. It's produced by the ovaries to a small extent and the adrenal glands in women, and it's produced by the testes, of course, in men, and also the adrenal glands. The effects of testosterone on men include spermatogenesis. I just talked about that, the manufacturing of sperm. Testosterone can cause sexual dysfunction or it can restore sexual dysfunction. It kind of depends on the picture. And also, of course, just like estrogen, testosterone in a male is responsible for the development of secondary sex characteristics. So I mentioned already, produced in the men, in the testes or the Leydig cells, and the ovaries or the adrenal glands for women. The adrenal glands for men as well, but it's a small production, right? They produce way more testosterone in their testes. So therapeutic uses, replacement is going to be the big ones. Most common, similar to what we were talking about in women. If we have a slow to develop male, they may consider testosterone. Definitely lowers the testes in an undescended testy person. Testosterone is used a lot for its anabolic effect, especially in paraplegics. For women, it's sometimes used for dysmenorrhea and also menopausal states. Testosterone is measured for women, menopausal women, most frequently, and it can help with some of the symptoms. Especially, it seems to be especially effective in the lower libido cases. Testosterone will also suppress lactation. So the side effects of testosterone, it's going to be retention of sodium chloride and potassium as well as water, and this can contribute to heart failure, and that's something to kind of think about. Jaundice is not uncommon. Nausea is not uncommon. Testosterone is going to be contraindicated in with prostate cancer and pregnancy. Women we can see virilization in women, and that's going to be specific with acne, growth of facial hair, deepening of the voice, and excess muscle development in women. One of the things we see with testosterone in men is impotence. And again, it sort of depends on the situation, because sometimes if a man has low testosterone and you replace it, it seems to have the opposite effect, right? It's kind of a virilization in men. But if their testosterone levels are not low and they're using testosterone inappropriately or for maybe an anabolic effect, then that can kind of disrupt the negative feedback cycle and can cause impotence. So it's sort of on a case-by-case basis there. We can see a decreased spermatogenesis. We can see gynecomastia, excuse me, and liver abnormalities, as well as psychotic episodes with testosterone administration in men. If we're giving testosterone to children, one of the things we want to watch for is premature closure of the epiphyseal plates and stunting of the growth, and also abnormal sexual maturation. So I think we sort of have hit these therapeutic uses. The big one is going to be replacement in both men and women, probably more common in men, but in women as well. I mentioned the anabolic effects, dysmenorrhea, suppression of lactation, and one of the things that we haven't talked about here for women is sometimes we will use testosterone, and actually men as well, use testosterone in cases of inoperable breast cancer. And that's sometimes preferred over estrogen because we know that some of these breast cancers are estrogen sensitive. Fibrocystic disease in females, the addition of testosterone seems to inhibit the gonadotropes and therefore decrease the natural estrogens, which fibrocystic breast disease is oftentimes associated with too much circulation, high levels of circulating estrogen, or an inability to metabolize estrogen. I think I mentioned that in the beginning of this conversation. All right, so that's the end of this. So that was estrogen, progesterone, and testosterone. So in the next video, I'm going to come back and I'm going to talk to you about oral contraceptives.